These are the pre-gestational, and we're going to talk about diabetes. You already should know about diabetes from MedSurg, so this should be a review for you. Diabetes mellitus, you already know, it's an endocrine disorder. It's a problem with the metabolism of carbohydrates. And so that is usually a result from an inadequate production of or an inadequate use of insulin. It can be from cellular and extracellular dehydration, and it's a breakdown of the fats and proteins for energy, and that's it. And so in pregnancy, we already know the baby is needing the glucose. So if mom is having trouble metabolizing glucose or doesn't have enough insulin, or all of a sudden she's developed a gestational diabetes, then not only is the mother going to have problems, the baby is not going to get what it needs. So, gestational diabetes, any kind of glucose intolerance with the onset or initial diagnosis during pregnancy, and this occurs in about 7% of the United States pregnancies. Several women who may be predisposed to diabetes type 2 may have gestational diabetes. The high risk factors are a marked obesity, a prior history of gestational diabetes, glycosuria, or a strong family history of diabetes. Effects of pregnancy on carbohydrate metabolism. In early pregnancy, there is an increased insulin production and tissue sensitivity. In the second half of pregnancy, there's an increase in maternal insulin resistance. Now, why is that? Who's needing glucose, right? So, we already have an insulin resistance there so that the baby is getting as much glucose as it can. However, if mother has an insulin resistance because of a diabetes or gestational diabetes, then there's a problem. And if you're having trouble understanding that, go back and review it, because we're not going to spend a whole lot of time talking about the patho. So, the maternal risks with diabetes mellitus: hydramnios, preeclampsia, and that usually comes with what? High blood pressure, proteinuria, high albumin, ketoacidosis, retinopathy, and an increased susceptibility to infections. Everything except for the hydramnios and preeclampsia. The other problems that one can have from diabetes mellitus, the pregnant client can as well. The fetus problems, neonatal risks, perinatal mortality. If she's a diabetes type 1, many times through preconception counseling, sometimes depending on how hard to control their diabetes is, they are often counseled to not become pregnant. The fetus also has risk of congenital anomalies, macrosomia, IUGR, which is intrauterine growth restriction, respiratory distress syndrome, polycythemia, and they are at a higher risk for hyperbilirubinemia, or we often call that jaundice. Gestational diabetes, the high risk factors usually in non white women: a prior history of gestational diabetes, a prior birth of a large for gestational age infant, and oftentimes marked obesity. She may also have had a history of polycystic ovarian syndrome, hypertension, glycosuria, or a very strong family history of type 2 diabetes. So, how do we screen for diabetes mellitus? We screen as soon as possible. We look for the H1C equal to or greater than 6.5%, a fasting glucose level of greater than 126, or a 2-hour plasma glucose of greater than 200 during an oral glucose tolerance test. If we do an initial glucose and it's too high, then she's going to come back in and we're going to do an oral glucose tolerance test to see how she's metabolizing sugar. Women who determined to have diabetes at this visit will be diagnosed with diabetes and not gestational diabetes, because if they have a really high sugar and it's before we've even done a glucose tolerance test and their fasting sugar is really high, they may be diagnosed with diabetes type 2. Average risk for gestational diabetes mellitus. We screen them at 24 to 28 weeks. We do a 75-gram glucose. It's called a 2-hour oral glucose tolerance test. And we determine what their levels are while they're fasting at 1 hour and again at 2 hour. So we don't want them to eat or drink anything. They come in, they drink 75 grams of this really sweet tasting glucose drink. And then we draw glucose at 1 and at 2 hours after they've ingested it. Now, these are important to know to make the diagnosis of GDM or gestational diabetes. If her fasting glucose exceeds 92 milligrams per deciliter, after 1 hour, if her glucose is greater than 180, and if her glucose is greater than 153 after 2 hours, then she would be diagnosed with gestational diabetes. And this is from ACOG in 2011. All pregnant women screened we should use the two-step approach. Women at average risk at 24 to 28 weeks, we might start with a 50-gram solution and do a 1-hour oral glucose tolerance. And this glucose would be given at any time of the day. We draw glucose after an hour later, and there's no requirement for fasting. Or we may do a 3-hour glucose test if the plasma glucose level is equal to or greater than 140 milligrams. Most of the time, if they have a high glucose level, you are going to see the physician go ahead and do the 2-hour glucose tolerance test to be safe. We want to maintain physiological equilibrium of insulin availability and glucose utilization so that mom has what she needs for energy and the baby has what it needs for growth. We want to have a healthy mother, a healthy newborn, and we want mom to be aware of these changes that she needs to expect. And we want to, if she does have gestational, we want to have stringent blood glucose control. And she needs to know these things before conception and during the first trimester. And if it is determined that she has diabetes type 2, or she may have a developing diabetes mellitus, we need to refer her to specialists because there could be problems with the fetus. So, what are the dietary recommendations if she does have diabetes mellitus? Why are we going to increase her caloric intake by 300 kilocalories a day? For a normal weight woman, she's going to need about 30 kilocalories per kilogram of ideal body weight during the first trimester. Why? That baby's growing fast. And then during the second and third trimester, 35 kilocalories per kilo of ideal body weight during the second and third trimesters. And these are good calories, not empty. So it's essential for us to determine her insulin needs and assess her glucose control. Regular monitoring by her healthcare provider and frequent self-care monitoring, and we need to stress to them why this is so important. Insulin requirements. Gestational diabetes. Not all women are going to need insulin to maintain normal glucose level, but sometimes they do. Pre-gestational diabetes is they typically have type 1, and usually with type 1 they're already on insulin. The human insulin is least likely to cause her to have allergic reactions when she's pregnant. Sometimes they may have a combination of an intermediate and a regular insulin. Um, Recommended regimens vary. It just depends on the individuals. And those of you who have taken care of diabetics in the hospital have seen this because there's different types for different people. Until recently, the oral hypoglycemic agents were not used during pregnancy, but recent research does suggest that glyburide and metformin could be safe for women with gestational diabetes. So, to assess the baby, ultrasound, of course. A quadruple screen is very important to assess for neural tube defects. Um, that's the alpha fetoprotein, and if you remember, it's very important that this is done at a specific time during pregnancy. The human chorionic gonadotrophin may be done, or an unconjugated inhibin A. There may be a fetal echocardiogram and, of course, a fetal biophysical profile. We may need to do a daily maternal fetal status evaluation, a non stress test, and some providers may determine they need a contraction stress test or an amniocentesis. During the antepartum period, teaching is very important. Um, what should she expect? What types of changes should she expect? And this is pre-gestational now. Make sure you understand what that is. Carefully consider the risk and benefits for prescribing any medications. It is very important that she maintain stringent glucose control before she decides to conceive, and especially during the first trimester. She may need to go see the ophthalmologist and or the nephrologist. Most women with any type of diabetes are allowed to go to term with spontaneous labor, but sometimes we may have to decide to induce labor to avoid problems because of decreased perfusion as that placenta begins to age. And sometimes with diabetes, we have a decrease in placental function the older it gets. It just depends on the individual. Sometimes, if there's evidence of fetal distress, we may have to perform a cesarean. Birth before term could be indicated with diabetes if she's having vascular changes, if her blood pressure is getting worse, or if there is evidence that the baby has all of a sudden stopped growing and there's intrauterine growth restriction. Preterm birth, sometimes often by cesarean, has to be considered if the fetus appears to be deteriorating. Intrapartum, during labor, we want to measure maternal glucose levels hourly because we're going to have to control those maternal glucose levels. If she's diabetes mellitus type 1, sometimes you may see that she's going to be on an insulin drip. Insulin drips are usually managed in ICU. These insulin drips will be managed in the labor room. The reason being diabetes, hyperglycemia, right? So the baby is used to receiving high levels of glucose. The baby is going to be born. And to prevent neonatal hypoglycemia, we may have to give mother insulin because we need to what? Metabolize the glucose so that it can be used. Additional insulin may not be needed during the second stage of labor, but it might be needed for mom in the immediate postpartum because just like neonatal hypoglycemia, we don't want mother's glucose all of a sudden bottoming out. Just like whenever with diabetes type 1, when they're exercising, what about the insulin? Do they need more or less? Same thing in labor. Why is mother getting insulin? We think it's to metabolize the glucose to use it. We're giving insulin to bring the glucose down, yes, but it brings the glucose down because it's being metabolized the way it needs to be. Postpartum, we have to assess glucose. We're talking about diabetes type 1 still. Maternal insulin requirements will drop significantly because now the baby who's been needing this extra has now been delivered, and so she may not need as much insulin as she was needing. Breastfeeding is encouraged. That helps to manage the glucose levels, and caloric needs will increase if she is breastfeeding, so we have to pay attention to if the insulin needs to be adjusted or not. Glucose control during postpartum. Usually, insulin requirements will decrease if she has gestational diabetes, because she has gestational because of the pregnancy. Once the pregnancy is over with, seldom are you going to see them needing insulin. Elevated glucose levels, if she ends up going into a type 2 diabetes, which she might have been predisposed to it with gestational, sometimes we can treat that with an oral anti-hyperglycemic. But if she is breastfeeding, she cannot take oral hyperglycemics because it's going to cause the baby to become hypoglycemic. She's going to be reassessed at 6 weeks postpartum to determine if her glucose levels are back to normal. If they are, we're going to reassess again at a minimum of 3-year intervals. Now, this is someone who is gestationally diabetic, not if she's pre-gestational or diabetes type 1. During postpartum, we want to have a good relationship. If the newborn is needing special care, we need to educate and encourage the parents to be involved. If it's proper to do so and the baby can, we encourage breastfeeding. Home glucose monitoring if it's appropriate, and family planning, because if she had a difficult time with glucose control with this one, chances are if she gets pregnant again, it may be increased. So we need to talk to her about family planning, how to manage birth control if she's, because she can get pregnant again during this 6-week postpartum period. So barrier methods of contraception can be used with spermicides. Those are safe. They're effective. And often if they are insulin dependent, this is often the method of choice, because some of the others are contraindicated because they're hormones. And we have to be careful with those because insulin is a hormone. All right, so now we're going to talk about anemia and pregnancy. So I'm going to pause for a minute and I'll be right back. Okay, I'm back. Now, it's very important you realize I am touching the high points. I do have some resources that I will send you, and I have an extra resource I will give you to help you understand diabetes and pregnancy. And I have a whole lecture that I am going to give you to help you understand it a little bit more, but definitely read and get it in your head. And I have a virtual sim that we will go over with gestational diabetes. But right now we're going to talk about anemia and some other things that go along with pregnancy that will cause the mother to be at risk. Iron deficiency, we've talked a little bit about this already. It's the most common complication of pregnancy. So this is whenever you have an inadequate iron intake and hemoglobin is going to be below 11. Now this is different than physiological anemia that we've talked about earlier in the semester, where red blood cells are more dilutional, and so it looks like she's having an anemia, but it's more physiological. So the prevention of iron deficiency is we just give her supplemental iron. or folic acid in an iron-rich diet, and what are some of the complications of giving her supplemental iron that we have to be careful of. You need to know about that. So, maternal implications: if she's iron deficient, she'll be easily tired. She's going to be more susceptible to infection. She's got increased chance of developing preeclampsia or going into eclampsia. That's whenever her blood pressure is getting high. She started having blurred vision, seeing spots. She may start having seizures, and she may develop postpartum hemorrhage. This individual can't even tolerate a minimal blood loss during the birth of the baby. And if she has an episiotomy, she may have delayed healing from a C-section incision or an episiotomy incision. Fetal complications. Think about it. Anemia, when the maternal hemoglobin may be less than 6. There's an increased risk. Low birth weight, a preterm birth, a non-reassuring fetal status, and sometimes the baby may not live. Fetal hypoxia during labor is often due to impaired uteroplacental oxygenation, which is dependent on good perfusion. If she is anemic, her perfusion is decreased. Sickle cell anemia is a recessive autosomal disease. We've talked a little bit about it a couple of weeks ago. It's an abnormal formation of normal adult hemoglobin. It's on the hemoglobin A. It's primarily from African descent. It's occasionally seen in Southeast Asian or Mediterranean descent. There is a decreased oxygenation, which causes the sickling of the red blood cells, and this is what causes us to have problems with not only mom but also with the fetus. Hemoglobin levels are maintained by intense erythropoiesis, and this is not an iron deficiency anemia. It's a folic acid deficit, so she needs to take folic acid supplements at least 1 milligram a day during pregnancy. When she's having a crisis, she'll have profound anemia. She may be jaundiced. Her temperature will go up. She may have an infarction, and she will be in very acute pain. And those who have sickle cell usually can tell if they're beginning to have a crisis, and they'll seek attention. Treatment during a crisis: naturally rehydration. We're going to have to start IV fluids, give her oxygen because the cells are sickling, put them on preventative antibiotics, analgesic, and of course we have to monitor the fetus throughout the crisis. Maternal pregnancy often will aggravate sickle cell anemia, and it may cause her to have a heart attack or an infarction. So maternal mortality is rare, but sometimes we might lose the baby. So these are the individuals who really would benefit from preconception counseling before getting pregnant. Significant risks are pyelonephritis, acute chest syndrome, and gestational hypertension. Sometimes she can go into congestive heart failure or acute renal failure. So if she's pregnant and she has sickle cell, we want to maintain her health as much as possible and reduce the anemia. Prompt treatment of infections are important, and she should be aware of her disease and take care to not get exposed to infections. She will need oxygen supplementation throughout labor. IV fluids will closely monitor the fetal heart rate, and she is going to be more at risk for clots, so we want to put anti-embolism hose on her, especially during the postpartum period. Fetal implications. We have a high risk for fetal death because of the sickling of the cells. It attacks the placenta. It recently, though, with new monitoring techniques and new treatment regimens and better, more closer more closely monitoring and good prenatal care, this has been decreased. She definitely is at risk for preterm labor, though, and a premature infant or intrauterine growth restricted fetus. Folic acid deficiency is most common cause of a megaloblastic anemia. Um, Potential causes of a folic acid deficiency, and this often happens during pregnancy and lactation. So, if they have this type of anemia, 400 milligrams every day. It's best to start taking this before conception and at least through the first trimester. It can be treated with 1 milligram of folate every day. Now, I'm going to go over some of these. Are you going to be tested at length on all of them? You realize on a 50-question exam, we can't get in depth on all of these. Maternally with folic acid anemia, it's the second most common cause of anemia in pregnancy. Um, the more severe the deficiency, the more high risk she is. She might need a blood transfusion after delivery. She is prone to hemorrhage and she's also prone to infections. Good sources of folic acid: fresh green leafy vegetables, red meat and fish, poultry, and legumes. Um, but realizing these are easily destroyed by overcooking our food or cooking with a lot of water. Of course, fresher is better, non processed foods, and as my grandmother used to say, you don't cook your stuff to death, but naturally, your red meat doesn't need to be raw either. For the fetus, they're at increased risk for neural tube defects, spina bifida, meningomyelocele, and anencephaly. Anencephaly is whenever you go above the eyebrow, the top part of the skull is missing, or they don't have a total closure of the neural tube around the back. Sometimes you may see a dimple over the where the sacrum area is. All right, alcohol and illicit drugs. We talked about fetal alcohol syndrome a little bit already. It's physical and mental abnormalities that vary in severity and combination. There's no final answer on how much alcohol a woman can safely drink. Best advice we can give is there are dangers with drinking alcohol. It's best not to drink and while you're pregnant. Chronic abuse, mother will be malnourished, so naturally she's going to have a folic acid and a thiamine deficit. It causes bone marrow suppression, increased incidence of infections, and liver disease. Intrapartum, she may have withdrawal seizures if she's used to having alcohol as early as 12 to 48 hours after not having a drink. Postpartumly, she could go into delirium tremens. The newborn will also suffer from withdrawal. Nursing care, if she is an alcoholic, and I know she is going to go into withdrawals, my job is to follow orders for sedation, um, manage seizure precautions and IV fluids. It is okay for her to breastfeed because she's going to be ceasing her alcohol consumption. For the baby, though, mental deficits, microcephaly, midfacial hypoplasia. I believe I've shown y'all some pictures of what they look like. The baby could have cardiac anomalies, IUGR, teratogenic effects from the alcohol, and the baby could be lost during utero. Fetal alcohol syndrome or fetal alcohol effects from mother drinking. So if she's taking smoking crack or cocaine in any form, while she's pregnant, here are the things that can happen: seizures, hallucinations, pulmonary edema. She can have a cerebral bleed. She can go into respiratory failure, and she can have heart problems if she chooses this lifestyle during pregnancy. Maternally, she can have a spontaneous abortion, an abruption, intrauterine growth restriction, a preterm birth, and even a stillborn. I've cared for several stillborns after mother has decided to use cocaine. Potential fetal effects: intrauterine growth restriction, a small head, a cerebral infarction, which is like a stroke, a shorter body length, altered brain development, malformation of the GU tract, and also low APGAR scores. And the other problem here is this baby is going to be born addicted as neurobehavioral disturbances, irritability, exaggerated startle reflex, very labile emotions, increased risk of sudden infant death syndrome, and usually learning problems will show up later on. So, cocaine use in breastfeeding infants, they'll be very irritable, they will vomit, diarrhea, have dilated pupils, and apnea. So, if we know she has been using cocaine, we do not allow her to breastfeed because the baby will still get the effects from the drug. So, if she's used meth, and I've taken care of some of these too, fetal implications: small for gestational age, low birth weight, they won't arouse very easy, they'll have lower scores on tests, lower verbal memory and visual motor integration. And plus, they're born addicted as well, and we have to carry them through withdrawals. If she smokes marijuana, there's no strong evidence that it has teratogenic effects, but there is evidence that she may go into preterm labor. It's difficult to evaluate how heavy use will impact pregnancy. There are social factors that influence the direct results of using marijuana, and we do know that smoking poses risks during pregnancy. It is highly recommended to discontinue marijuana use before and during pregnancy because it has been known to cause premature labor. MDMA. This is ecstasy or Molly. Very little is known about its effects on pregnancy, but studies have found that dose-related delay on mental and motor development at 1 year of age of children who are born to women who have used this drug. There's been no effect seen on language or emotional regulation or parenting stress, but still, even though we've heard about this drug for a while, still not quite sure all the effects that it can have. Heroin is terrible. There's increased incidence of more health problems, and heroin is one of the most difficult drugs for mothers to get off. Mothers will they will be poorly nourished, iron deficiency anemia, risk for preeclampsia, and definitely higher risk for sexually transmitted infections. They often rely on prostitution to support their drug habit. The fetus is definitely at risk for preterm labor, preterm birth, IUGR, being stressed in utero, so run the risk of meconium aspiration. And during withdrawal symptoms, these babies are suffering. They'll be very restless. Their cry is very, very shrill. It's different than a regular newborn cry. They'll be very irritable. They're trying to comfort themselves by sucking on their fist. They will vomit and they will have seizures, and this can last for several days. And we have seen babies be on withdrawal treatment for quite a while, and they have other problems, and they may stay in the NICU for 2 or 3 months. Fetal implications too, they can't bond with their mom. They're very hard to console. And because she has abused drugs, then there's other issues going on. This baby may not get to go home with this mother. So it's risk for parenting problems. Or if the baby does go home with her and she still has her drug habit, then we run the risk of the baby being abused. So, psychological factors to the childbearing family. We're going to go over some of these because there are problems, and there are some psychosocial problems that can occur in the postpartum period. Um, Disorders among adults in the United States, we have like a 22.5%. This was back in 2014. 1 in 4 adults with psychologic disorders. And this is characterized with alterations in their thinking, in their mood, or their behavior. Depression is the most common, and it often goes untreated. In pregnant women, 9 to almost 13% will have some type of major depression. And sometimes this is associated with an increased likelihood for preterm birth, an SGA newborn, or a low birth weight infant. And she may be unable to concentrate or process the information we're giving her if she has depression. Untreated depression, she won't take care of herself, has a poor appetite, poor weight gain. She may be trying to medicate herself. The baby, it may come early. She may go into preterm labor. At risk for maternal suicide, there's sometimes poor maternal infant bonding, or she's not able to tell us how she's feeling. So she might be on the irritable side, or she may be on the more withdrawn side. So, what about bipolar disorders? She may be in the depressive phase and very depressed, or she may be in the manic phase and she may be exhibiting behaviors that are very dangerous to her or dangerous for the baby. She may start using alcohol, may start exhibiting reckless behaviors like driving real crazy or driving without a seatbelt, or she might start having unprotected sex. If labor occurs while she's in her manic phase, she may be very hyperexcitable and she may exhibit poor judgment. And so we have to be able to recognize these things and help during this phase. Anxiety has a cluster of disorders that we need to be aware of. Panic disorder or obsessive compulsive post traumatic stress disorder. This is happening more and more. It's not just military, which we see this more in our military population, but it can be post traumatic from any type of traumatic event that happened in her life. A general anxiety disorder, or even some of the phobias. There's just a wide range of symptoms in pregnancy and laboring women that can come from an anxiety disorder. And anxiety, just like pain, it affects the progress of her labor. And the behaviors that she exhibits are very characteristic of this disorder. Sometimes they're having a panic attack and you think they're having a heart attack, and we just have to find ways to comfort them and help calm them. Schizophrenia is probably the most disabling of the disorders because they can't manage their emotions. Um, they have difficulty with interaction with people, and they have difficulty with thinking clearly. Her behavior may be very inappropriate, or she may be withdrawn. We may not even be able to communicate with her. And unfortunately, the medications for schizophrenia are very teratogenic, and they're contraindicated for pregnancy. And should a schizophrenic person become pregnant, they're very difficult to manage. So they have an increased incidence for preterm birth and low birth weight, small for gestational age. A lot of times they've become pregnant, didn't know it, they're on their drugs, and so there are placental abnormalities. They are at high risk for antenatal hemorrhage, and that's whenever they run the risk of having an abruption or a placental bleed that could cause them to lose the baby. So, for any of the psychological disorders that could occur during pregnancy, this is why prenatal care is so very important. We want to screen them for depression or anxiety. We want to do what we can to help decrease her anxiety, especially if she's prone to having panic attacks. We need to encourage them as best we can, give them clear information as best we can, keep them oriented to what is actually going on, promoting optimal functioning while they're pregnant and while they're in labor. And based on our careful assessment, that's whenever we can determine what type of pharmacologic measures we can do. And this is very individualized. So, during their first prenatal visit, all the things that we would do normally, but we have to add to it her marital socioeconomic status. How does she cope? What is her support system? Has she had any previous diagnosis or has she been treated for her psychological disorder? What type of treatments is she on? Has she been in the hospital for any of these episodes? Has she been having thoughts of hurting herself or hurting others? Because we need to know all of these things at the first visit. Naturally, anxiety may be one of her nursing diagnoses, fear of the unknown because of labor. We're going to be touching her. We're going to be doing invasive procedures, and you can understand why these things may set someone with a psychological disorder, set them into a manic state, or set them into a catatonic schizophrenic state. And definitely coping because of increased anxiety, increased stress. Pregnancy, labor, delivery, postpartum phase, those are stressful to some women. So, what are our anticipated outcomes? We want to decrease the physiological and psychological stress. We want to increase their comfort. We want to have a trusting relationship with them, and we want to keep them oriented as best as we can. We want to help them use their coping mechanisms effectively. We definitely want to get our support team in, social services, those people who can help us with getting help to help manage this whole situation. We want to promote their verbalization of their feelings and help to decrease fear and help bring her support system in if they're supportive. If they make things worse, we may not need them. All right, we're going to talk about AIDS a little bit in neonatal implications. We have mentioned this a few times, and naturally, we're not going to go in depth because you talked about sexually transmitted diseases and fundamentals, so we're just going to talk about it as a complication here. HIV does cause AIDS. We know what the mode of transmission is blood and blood products, other body fluids, semen, vaginal fluids, and breast milk. So if she is HIV positive, she won't be able to breastfeed. It affects the T cells and decreases the body's immune responses. Diagnosis, because the antibodies do develop, and we do an EIA test to confirm with a Western blot test. And it's usually confirmed in one of four stages for public health surveillance of adults over the age of 13. The AIDS diagnosis is made when the HIV positive person develops one of the opportunistic infections, and I believe y'all have already studied those in previous courses. Signs and symptoms, sometimes she may be asymptomatic. Sometimes, like I've told you in class, they don't know they have HIV till they come in, do not have prenatal care. We do a test, and she has HIV. She may be exhibiting fatigue or anemia, malaise. She may start losing weight and lymphadenopathy. She may develop diarrhea, have fever, a neurologic dysfunction, some type of immunodeficiency, or Kaposi sarcoma, if you remember from either fundamentals or med surg. I don't know where you might have talked about HIV. This is the late stage of HIV, and usually they have developed AIDS by the time they are showing Kaposi sarcomas. So therapy, of course, is ART, antiretroviral therapy. If pregnancy is considered, we have to focus on maintaining the health of the mother before, during, and after the pregnancy. We want to prevent transmission to potentially a seronegative father. So if mom is HIV, father is not, we want to talk to them about how to prevent transmission. And we definitely want to try to prevent mother to child transmission if we can. It's very difficult. It's a very slim. The child HIV transmission, it can occur during pregnancy, and it can also occur through breast milk. Majority of all these infections occur oftentimes during labor and birth. This is another reason why we often try to suggest and highly recommend a cesarean if at all possible, instead of her going into labor and going through the birth process, because of the mixing of the fetal and maternal blood during labor and birth. There is a decreased rate of transmission in certain women, especially if she's been given the ART therapy before pregnancy. And if she chooses to have an elective cesarean at 38 weeks before the membranes have ruptured, and we do not promote breastfeeding in these women. And following birth, HIV infection in infants diagnosed, we use a virologic assay test, and we start these drugs on the infants immediately if the test is positive. And sometimes, if we can start these drugs immediately, it can prevent the HIV infection. So, we want to identify those women who are at risk. And we would love for HIV testing to be a routine part in prenatal care, and ensure that the testing is voluntary, and we want to be an informed decision with them. But if she has not had a monogamous relationship, and if she has had history of problems, we really want to try to encourage her to go ahead and have a test and express to her that it is highly confidential. We'll do the ELISA test first, and if it is positive, then we confirm it with the Western blot. A maximally suppressive ARV is recommended to all infected women, and this will reduce the rate of perinatal transmission. We have to make a decision to either start this in the first trimester or delay it until 12 weeks gestation. It depends on what her cell count is, what her RN levels are, and what her maternal conditions are. If she's already showing some of the symptoms of HIV, we're going to go ahead and start her antiviral treatment during the first trimester. highly active antiretroviral therapy is recommended, which is Retrovar and Zidovudine. It's a longer duration therapy and it's preferred for the first trimester and no later than 28 weeks gestation. And this is just a combination of the regimens. Am I going to expect you to know all these? No, this is for your knowledge so that you have an idea of if she is got a higher cell count, then this is the what we have to do, and it's a longer duration. Comorbid conditions if she's got HIV, and this is the part we hate to talk about. We're going to have to evaluate because many times they will have other sexually transmitted infections besides HIV. Usually, oftentimes, they may have TB, cytomegalovirus, toxoplasmosis, and cervical dysplasia, which is a predecessor to cervical cancer because her immune system is so deteriorated. We'll give her a hepatitis vaccine if she has no history of hepatitis B. She's going to have the annual flu shot. She needs to stay away from any type of viral infections because she will easily catch them, and they're like a virus on steroids. They are much more pronounced whenever she has HIV. She's going to get routine perinatal lab tests. We're going to get platelet counts and, of course, CBC. And we're going to repeat that every trimester. And she's going to get CD4 and T lymphocyte counts very frequently. We've got to start teaching because now she's going to have an HIV possibly infected baby. She's going to have to learn how to prevent cross contamination to other children who are home and other people who were in the home. Watch for signs of complication, weight loss, fever, infections, oral infections, pneumonia, enlarged lymph nodes, enlarged liver, enlarged spleens. Like I said, anything that a normal person could have, it's more pronounced if she has HIV. Visual examinations and fundoscopic exams are going to be done. We're going to do weekly non-stress tests starting at 32 weeks. Ultrasounds, biophysical profiles. We really want to avoid invasive procedures because we want to avoid the potential to contaminate a non-infected infant. We have a high chance of this infant not being contaminated if we can do all of these things to prevent it. With the HIV, we would love to schedule cesarean at 38 weeks if possible. Women with a RNA level of greater than 1,000 copies, women with an unknown RNA level near the time of birth. And this is regardless of whether or not she's been on ARV therapy. This is how we can hopefully try to prevent any type of cross mixing of the maternal and fetal blood if we can do a scheduled section before there's a rupture. Complications, though. She has increased risk of postpartum hemorrhage. She's at increased risk of intrapartum hemorrhage. She's at increased risk for postpartum infection, poor wound healing, genitourinary infections. So we've got to do careful monitoring and appropriate therapy. It's hard individuals to take care of. They have to have a lot of education, and a lot of times it's a lot to take on, and now they have this baby. So now we're going to talk a little bit about the heart. It should be a review. Cardiac demands, we already know during pregnancy there's increased demands on cardiac output, heart rate, and blood volume. If she already has heart disease, she's got decreased cardiac reserve, and this leads to difficulty in accommodating that higher workload that we have during pregnancy. So, congenital heart defects, I think I've talked about these some in previous lecture. So, we're just going to kind of go over them: ASD, VSD, PDA, coarctation, or tetralogy of Fallot. These are common maternal congenital heart defects, something that she had during infancy. And there's still some cardiac insult somewhere. So these are some congenital defects that could pose a problem. So it depends on the specific defect if she has implications during pregnancy. If it has been surgically repaired and she has no history of or evidence of organic heart disease, then pregnancy is okay. But if she has a chronic cyanosis from one of these defects, she's at increased risk for complications, and so is the fetus. So, congenital defects that are contraindicated for pregnancy: Eismenger syndrome, pulmonary hypertension, an uncorrected coarctation, a severe symptomatic aortic stenosis, or Marfan syndrome. So you can just review over what those are. That's above what our generalist course is. But if just know if she has some congenital heart defect that she is having problems from, she is highly discouraged from getting pregnant because it's going to make these worse, and it's going to be worse on her, worse on the fetus. Rheumatic heart disease, increased blood volume during pregnancy, coupled with the need for increased cardiac output, is going to stress the heart of a woman who has mitral valve stenosis that developed as a result of rheumatic heart disease. So, this is going to increase her risk for developing congestive heart failure because she's got a mitral stenosis. Her heart can't take on that extra volume. Even if she's asymptomatic when she gets pregnant, she's still going to be at risk because as the fetus grows and that cardiac output demand increases, she's going to be at risk for congestive heart failure. Mitral valve prolapse. Usually they can tolerate pregnancy well, but sometimes she may have symptoms caused by an arrhythmia like a palpitation. She may have chest pain. She may have dyspnea. Usually she's going to be treated with Inderal or Indocin. She needs to limit her caffeine intake. If she has a peripartum cardiomyopathy, I've talked to you about some of the myopathies in pregnancy. Often it's rare, but it can be a serious dysfunction of the left ventricle. And sometimes this can occur in the last month of pregnancy or in the first 5 months postpartum. And she's had no history of heart disease. This myopathy has a higher maternal mortality risk and it increases with maternal age. And it can be after she's had 4 more live births, and often it occurs in African descent. They often present with anemia or with an infection. So our treatment focuses on correcting what's going on. What's the underlying abnormality? So she might have to be placed on DIG or a diuretic, vasodilators, anticoagulants, sodium restriction. She may be placed on strict bed rest, and a subsequent pregnancy is strongly discouraged if she lives through this one. General goals of cardiac disease: we want to diagnose it early, and we're hoping we diagnose it before she becomes pregnant. Ongoing management is very important. We're going to do an echo, a chest x-ray. We're going to listen to heart sounds. She may need a heart cath, and these are essential for establishing the type and severity of the kind of heart disease she has. This is why preconception counseling is so important, for us to try to find out some of these things ahead of time. So this is from the New York Heart Association. Do I want you to memorize them? No, I do not. But this kind of gives you an idea of how we classify the functional capacity of the heart when she's pregnant. Class 1, she's asymptomatic. You don't see any limitations with physical activity. She's able to continue to do things and not have any cardiac symptoms at all. Class 2, she has a little bit of limitation with physical activity. She's asymptomatic when she's resting, but when she's doing normal, ordinary physical activity, you see there are some symptoms. Class 3 is marked limitation with physical activity. She's okay when she's resting, but whenever she's doing less than ordinary physical activity, getting up and walking up to the stairs, she's getting winded or she's having some dyspnea. Class 4 is whenever any type of physical activity produces discomfort. She's having symptoms of cardiac insufficiency or anginal pain even when she's resting, and she's having increased activity discomfort. Um, Walking up those stairs, she's having more discomfort. Walking to the bathroom. So these are the people who, class 3 and 4, would be those people who really need to think about it before they get pregnant. So, maternal implications. Classes 1 and 2, usually a normal pregnancy and have few complications. 3 and 4, they are at risk for very severe complications. We want to take care of these people in labor with 1 and 2. We want to try to make an easier labor for them. Pharmacologically, they may need drug therapy in addition to iron and vitamin supplements, antibiotic prophylaxis for sure. Um, but if there are uncomplicated vaginal and cesarean birth, if unless we suspect an infection, we don't need to do prophylaxis. If they're class 3 or 4, yeah, they're probably going to give them antibiotics. Coagulopathies, heparin does not cross the placenta. So we've got to be very careful. Um, Congestive heart failure, they may need thiazide diuretics and furosemide. Um, if she's having clotting problems, heparin is the one that she's going to have because it's not going to get to the fetus. Cardiac failure, she's going to have to be on DIG, antiarrhythmic drugs. Um, these do cross the placenta, but they don't have any known teratogenic effects. But we have to remember, if we don't take care of mom, we're going to have a compromised fetus. So we have to look at where the benefits outweigh the problems. Um, there is low risk for infective endocarditis, so routine antibiotic prophylaxis is no longer recommended for a vaginal birth, but it does have to be tailored to the individual woman on what's going on. So, our care. We've got to meet the patient's physiological and psychosocial needs. So, depending on the severity of the disease, depending on is going to help us prioritize our nursing actions. So they have to be educated, the woman and the family. What is her cardiac condition? How are we managing it? What's been done prenatally? What are we going to do during the pregnancy? What are signs of potential complications? Why do she need to monitor her diet? Why does she need to monitor activities? And what needs to be done throughout the pregnancy? Dietary: high iron, high protein, and essential nutrients, low sodium. Managing that sodium, the sooner the better. Fresh vegetables, no cans, no added salt. Move the salt shaker. Take a look at how much sodium is in just 1 teaspoon of salt. Look at how much sodium is in canned food items, boxed foods. things in bags that we love to mix up and cook really quick. So you may need a dietary person to talk to her and a nutritionist on how to cook, because if we cook instead of eating out, it's going to help on that sodium. Adequate calories to ensure normal weight gain. And these are our complex carbohydrates, not empty calories. We may need to talk to her about activity restriction to help preserve her cardiac reserves, especially 8 to 10 hours of sleep, daily rest periods with those feet propped up. Avoid infection at all costs. Every 2 weeks, we're going to do a cardiac assessment during the first half of her pregnancy and then weekly after that. This is especially important between weeks of 28 to 30 whenever her blood volume is at its maximum. Interpartum, we've got to reduce physical exertion that accompanies fatigue. What are you doing? Are you still working? Where are you working? Is there time for rest periods? Is there a place where you can go and sit down and prop up your feet? When are you getting the most tired? What time are you going to bed at night? We've got to do a frequent evaluation of her vital signs. If her pulse is greater than 100, respirations greater than 25, she may be starting to have cardiac decompensation, and so we're going to have to monitor that. We may even have to teach her how to count her own pulse and her respirations and tell her what she needs to do and when she needs to cough. We want to listen to her lungs frequently. Any rales? Does it sound wet? Any other signs of decompensation? Is she wheezing? What position does she have to need to be in for breathing? Semi-Fowlers or side lying with her head and her shoulders elevated. We may need to give her oxygen by mask, diuretics to reduce fluid retention, sedatives, analgesics, DIG, all these medicines as indicated. We're going to have to talk to the woman and her family of labor progression and how we're going to manage it. Collaboration is key. Continuous fetal monitoring, sleep and relaxation between contractions, because we want to cut down on her amount of decompensation. Emotional support. We want to give epidural anesthesia, and this is used to decrease any type of exertion. We're going to do close monitoring of her vital signs during the second stage of labor. Cardiac output during postpartum and blood volume are going to increase. It challenges the heart and it may lead to decompensation, especially in the first 48 hours of birth, because now all of that blood volume that was focused on going to the fetus, that fetus has now delivered. There's a big shift and a blood volume increase again into the central circulation, and we have to monitor her to see if she's going to be able to handle that. So she may need to stay in the hospital a little longer than the low risk woman, because we're having to see how she's going to compensate for that volume increase again until everything balances out. So she's going to need frequent assessment and monitor for signs of decompensation. She may have to stay in a semi-Fowler's position to keep her head and shoulders elevated. Gradual progressive activity, appropriate diet, stool softeners, because we do not want her straining and bearing down with Valsalva. We don't want to talk. We want to talk to her about the birth experience and what she experienced, and especially if she's thinking about getting pregnant again. And we need to encourage that maternal infant attachment if we can. There's no evidence that breastfeeding stresses the heart, so if she wants to breastfeed and she can, if she is comfortable with doing so, but we want to evaluate any of the medications that she may be on and the likelihood of passing these into the crossing over to the baby or affecting lactation. Sideline position with the head elevated or semi-Fowlers is warranted, and it can be done with breastfeeding. And we want to talk to her about any problems related to heart disease or any type of postpartum complications that she may start to have as a result of having cardiac disease, and now she's had a baby and it may make the myopathy worse. So she may need a referral for a visiting nurse to come and see her. She may benefit from some home health for a few days, for a few visits to make sure that she's doing okay. She may not be the person that can wait 6 weeks to go and see a doctor. It's 6 weeks checkup. Medical conditions, we're just going to talk about a few of them during pregnancy. Asthma, epilepsy, hepatitis B, hyperthyroid, hypothyroid, or maternal fetal ketonuria. These are some of those conditions that might need some extra attention during pregnancy. Multiple sclerosis is also one, rheumatoid, lupus, and tuberculosis. These are some things, if she has them and she becomes pregnant, she's going to need some extra attention. Asthma, the severity could improve, it could worsen, it could remain unchanged during pregnancy. Preeclampsia is a complication, growth restriction in preterm birth for an asthmatic. Management focuses on maintenance of adequate hydration, analgesia, and she has to continue her asthma medications, especially if we're during a time like springtime where triggers are more pronounced. Preeclampsia for the mother, prematurity, premature labor, low birth weight. Sometimes, if she has severe asthma because it affects oxygenation and perfusion, it could lead to perinatal mortality. Sometimes, even a mild exacerbation of asthma can cause hypoxia to the fetus. Asthma drugs pose a less threat to fetus than a severe asthma attack, so she needs to continue her asthma drugs. Epilepsy, most women with seizure disorders have uneventful pregnancies and excellent outcomes. The importance is preconception counseling, talking to a maternal fetal specialist about the safety of continuing their epileptic drugs, because they need to stay on their medicines. Seizures before pregnancy can foreshadow exacerbations during pregnancy. So they have to continue a medication that best controls the seizures, have better monitoring, alpha fetal protein levels, genetic screenings, all of those things. They need to begin folic acid prior to conception if possible, because folic acid and vitamin D are indicated throughout pregnancy. My son and his wife are expecting. They're hitting 20 weeks. She has epilepsy. She has been able to stay on her medications. Everything good. They're doing all of their screenings. Baby looks good. Progressing fine. It's better that she stay on her medicines and prevent epileptic episodes, because she can have grand mal seizures, and that would be more detrimental to the baby than taking the medication. Fetal implications, certain anticonvulsant meds are linked to increased incidence of congenital anomalies like cleft lips and heart defects, but use of the lowest dose is the most effective, as long as it's effective enough to prevent seizures. Multiple medications, though, with valproic acid should be avoided, and this is why preconception counseling is so important, and pregnancy planning is important for someone who does have epilepsy. Hepatitis B, these are the CDC recommendations. Test all pregnant women, which we do. Prophylactic treatment of all infants is done. Now, there are some, this is a consent. Moms have to sign a consent for babies to get HBAG, but most moms will go ahead and consent, and babies will go ahead and get on the prophylactic treatment. Vaccination of children and adolescents through 18 who have not been vaccinated. It is required for them to go to school, or vaccination of unvaccinated adults who are at risk. Those of us who are like my age, working in the hospital, we were required to go through the series of hepatitis B vaccinations, but now all babies get it. Moms sign a consent. If they don't get it when they're babies, they are required to get it before they go to school. Maternal implications usually does not affect the course of the pregnancy, but chronic Hep B virus carriers can infect others through blood or body fluid exposure. So if mom is a carrier, she can infect her baby. Chronic carriers can develop chronic liver disease and liver cancer. The fetal implications, it will occur at or near the time of birth. That's why we try to go ahead and vaccinate. Risk of becoming a carrier is related to the age of the individual at the time of the infection. Infants who are infected perinatally have the highest risk of becoming chronically infected if they are not treated. And this is one of those things that where we have to really educate our moms about it. Not just give them a piece of paper, educate them about it, of why it's important, and many times they'll go ahead and say, okay. Hyperthyroidism is a mild condition, and it's not dangerous for maternal. It's increased incidence of preeclampsia, though, and postpartum hemorrhage if we haven't controlled it. There's a serious risk of thyroid storm, which is brought about by stress, and it's high fever, tachycardia, sweating, congestive heart failure. But now, with better treatments, this rarely occurs because usually, if she's hyperthyroid, this has usually been treated before she becomes pregnant. When it's diagnosed during pregnancy, it could be transient, where it's just because of pregnancy, or it could be permanent, but it's easily treated. Fetal implications, it's usually a neurothyrotoxic problem is usually very rare. With mother on antithyroid drugs, even low doses, we could have a mild neonatal hypothyroidism. If she's taking higher doses, the baby could have a goiter or a mental deficiency, but we don't see this very often. Fetal loss is not increased in this. If it's untreated, though, she could end up with a spontaneous abortion or intrauterine death or stillbirth if she's having thyroid issues. Breastfeeding, however, is contraindicated because we don't want that baby to be getting anti-thyroid medication. Maternal, she needs to continue her therapy. At least half of pregnant women will require increase in the thyroxine dose. Serial ultrasounds are required to monitor the fetal growth with someone who has hyperthyroidism. She will need non-stress tests. But if she has if she's well controlled on her medication, sometimes it's not necessary. But we do consider beginning at 32 to 34 weeks if she's poorly controlled. Sometimes they are very non-compliant with taking their thyroid medication. So we need to know all of these things so we'll know how to manage them. Hypothyroidism, if the mom is not treated, fetal loss is very, very high, and the newborn is at risk for neuro problems. So we screen if we haven't lost the newborn for T4 and mild thyroid stimulating hormone. PKU. If mom has PKU, And we screen for this for everybody now in the state of Louisiana. We're required to do the little stick the heel and all the little circles that screens for PKU amongst a bunch of other things. Um, it's a low phenylalanine diet is mandatory before conception if she has PKU and during pregnancy to prevent this baby from having PKU. We advise the woman that her children are going to either inherit the disease or they're going to be carriers. Treatment at a PKU center is highly recommended. Um, Risk to the fetus if maternal treatment has not begun at preconception. She has a risk of mental retardation, microcephaly, congenital heart defects, and growth retardation. PKU infants are treated during their first week. Those of y'all who might have had the opportunity to go to Central, you may have seen some individuals who had PKU or untreated, or if they still show the film of PKU individuals who were actually residents at Central. The reason being because they were microcephalics and developmental deficits from PKU that was not screened. MS, exacerbation rate of multiple sclerosis is usually reduced during the second and third trimester, but it does increase during 3 months following the birth. If they do exclusive breastfeeding for the first 2 months, it could reduce her having a postpartum exacerbation of multiple sclerosis when it's so important for her to be all of her capacities in trying to take care of this baby postpartum period. She needs to have adequate rest. And because of decreased sensation because of the MS, she may have a near painless labor. Fetal implications, there's some evidence of slightly increased risk for prematurity and slight risk of lower birth rate infant. But there's increased evidence of a genetic disposition of this baby possibly developing MS at about a 3 to 5% rate. Rheumatoid arthritis, if she has it, it usually produces remission during the pregnancy for some reason, but it will relapse during the postpartum phase. If she's on salicylate therapy, she may be anemic because of blood loss during labor and delivery. Activity levels, if she has rheumatoid, she's going to need extra rest, particularly to relieve the weight bearing joints. She still needs to continue her exercises. If she's in remission, her healthcare provider may stop her medication while she's pregnant. For the fetus, if she's taking prednisone during the first trimester, the fetus may have an increased risk of cleft lip, or cleft palate. I'm sorry. If she's using medications in the later part of pregnancy, she may have preterm premature rupture of the membranes or a small for gestational age newborn. Lupus, careful surveillance of her blood pressure, spilling protein in the urine, and placental blood flow. Medications might be necessary to control exacerbations of lupus. With lupus, it's very, very hard to diagnose. It's a multi-organ disease. Common complications are preeclampsia, prematurity, fetal growth restriction. If she has a severe case of lupus, she really needs to be counseled to avoid pregnancy because she's at a high risk of not only losing the fetus but also losing her life because all organs are affected by lupus. Fetal implications, increased incidence of cesarean, a postpartum hemorrhage, or need for a blood transfusion. Increased incidence for prematurity, a small baby, or a baby with a congenital heart block. Neonatal lupus, the baby has a photosensitive skin rash, thrombocytopenia, neutropenia, anemia. All of these hopefully would resolve by 6 months of age, but you see a lot of doctor's appointments here. If the baby is born with congenital heart block, this is the most serious complication from lupus, and this often is diagnosed in utero. If the baby is born live, the baby may require a pacemaker. TB, if mama has TB and she's pregnant, incidence of pregnancy complications will be very high. TB skin screening is recommended for a woman who's in a high risk group. If TB is inactive due to her receiving treatment, isoniazid therapy is delayed until the postpartum period unless she's HIV positive and has close contact with a person with active TB, or she's had a skin test convert to positive within the last 2 years. This woman is going to have to get on treatment, and it is going to have to be started during during pregnancy. Women with active TB are treated with isoniazid or rifampin and ethambutol during pregnancy. They're going to need extra rest, limited contact with others until this disease becomes inactive. Fetal implications: higher risk of spontaneous abortion, suboptimal weight gain, preterm labor, increased incidence of mortality, and low birth weight. Congenital TB is very rare of in utero infection. Postnatal transmission risk is very high, though, because if mom has had it and the baby is born, it's possible mom is going to transmit TB to the baby. Inactive maternal TB, mother can breastfeed if it's inactive and care for her baby. If she has active TB, there needs to be no maternal newborn contact until mother is non-infectious. I think that's all I need to tell you about that. I'm not wanting you to memorize all these things. Fetal implications. Most studies show that if mama is having to take isoniazid, it has no teratogenic effects. Plus, mother's going to have to take it. She's got TB. The potential harmful effects from rifampin, that is still being investigated.